Hi, this is Dr. Dave. Welcome back to my channel. This video is about a medical mission that I went on to very recently in Jamaica. It all came about because one of my really good friends in medical school went to it last year. He loved it. He's going again this year. And almost last minute in December, he's like, do you want to come and join? I was like, yes, of course, why not? So in this video, I'm going to talk about what that experience was like as a practicing internal medicine intensivist physician in the US now, going in a rural community to practice this, what it's like to be part of a medical mission, and some of the pitfalls to watch out for. And also, I really do believe that all doctors or healthcare providers should do some sort of volunteer medical mission work at some point, because it'll actually help you be a better doctor. And I'll explain why throughout this video. But first of all, I'll start off with some of the basics of what the clinic was. Essentially, it's run through one of the churches that was built in a small community in Jamaica. It's been there for about 25, 26 years. They charge a very nominal fee for the patients to come attend this clinic, about $5. And part of that includes the assessment by the physician, vitals, and then whatever medications we prescribe as well, is all given to them part of that cost. Now, comparatively, if they go to any other clinic, public hospital, or a private clinic, the cost of seeing a physician is going to be several hundreds of dollars, plus the cost of medication is going to be several hundreds of dollars as well. Given the poverty and lack of accessibility, a lot of people can't really afford that. So a lot of people that came to the clinic were of lower socioeconomic status. Other things to consider, for me, going to a medical mission run by a church, I was apprehensive because I'm Hindu, I'm not Catholic or Christian, and I just didn't know what the setup of that would look like. And I'm also vegetarian, so that there definitely was some issues with food and diet in Jamaica, because, as you know, a lot of chicken and fish based dishes, which are amazing, but I couldn't try any of them. So a couple things to keep in mind, but the main apprehensiveness I had was about the religion part of things, and also the fact that, you know, I'm there to help patients and see people. I don't really want to support a religious organization without knowing what they really stand for. And also, I just didn't want to be like converted essentially, or like influenced in any way, because I don't really influence other people with my beliefs, and I don't want others to do the same thing for me. I want to make my own decisions. So thankfully, going there, it was actually quite nice. We stayed in this compound there's a nun's houses, there's the church, and then we had a doctor's house where me, my friend from medical school, and then another physician who's been there for about 20 years, who goes back every year, is a pretty successful academic physician in Toronto. We all stayed in the same house, and thankfully there was not a lot of pressure or anything like that for me to attend the religious ceremonies. I did attend the mass out of interest, but again, there was no kind of religious element to it that I was forced to partake in, and I chose not to partake in because my focus was for patient care and to kind of, you know, help provide medical services. So I think that's fine. We were there for 1 week, and clinics usually ran morning from 8:30 to 4 p.m. There were days where we finished early. The busiest day we had about 75, 80 patients arrive, but on average we're seeing about 20 patients per doctor. If there's only one doctor for that week, for example, then that one doctor would be seeing 80 patients. But thankfully there was 3 of us, so it was 20 patients per person, which is actually not that bad. Now, over to the medical aspect of things, there was a lot of very interesting things as a doctor that you encounter and that you need to consider. There's some very common pitfalls, and then there's common lessons that you can learn. Right off the bat, the language barrier was a big issue, because a lot of people speak in a dialect called patois, and they speak very fast. It's very hard to understand the English sometimes, especially with the elderly folk. And so it was very difficult to get a history. And as you know, in medicine, history is king. I mean, that's going to tell you what the diagnosis is, whether the patient's taking their medications, how compliant they are, etc., etc. Now, for example, one of the ladies came in wanting a refill for a diazepam, which is a benzodiazepine. She says she takes that for sleep, which is not ideal for sleep, and it can cause dependency issues. So I was really trying to figure out, are you taking this regularly? Because the last prescription said PRN for sleep. And she's like, yeah, I ran out. But the last prescription was like 4 months ago, and she was given 20 tablets. And I was like, well, are you using it nightly? Is it helping with your sleep? And she's, her responses were very simple. She's like, yeah, I need it. Yes, I need it. And commonly all the patients would say, yes, doc, or yes, sir. And even if they don't hear the sentence fully, they're like, yes, doc, or yes, sir. And there's a lot of patriarchal kind of sense to their approach to the doctor, which is in a way good, but also in a way bad, because oftentimes they're not being completely upfront, and you also don't know whether you can rely on what they're saying. So I didn't know whether this lady was taking diazepam, and yet I refilled it because that's what she was there. But this is a real issue for patients who come in for high blood pressure, high diabetes, which was the most two common conditions that we saw. Uncontrolled hypertension, uncontrolled diabetes, A1Cs of 15, systolic blood pressures over 200 that we saw in the clinic as well. And so, you had to learn how to manage that. Now, we know what the guidelines-based stuff to do is, and we know what we do in Canada and the US. Patients with a blood pressure of 200, they're getting sent to the ER as a hypertensive urgency. If they have end organ damage, you do blood work, check for end organ damage to see if it's a hypertensive emergency. Now, we don't have immediate blood work accessible. Patient would have to pay for the blood work, and the nearest hospital is an hour, 2 hours away that the patient has to pay their way to get there, and also pay for the hospital services. So you can't just tell them to go to the hospital, and oftentimes you just have to learn to manage these severe conditions and abnormal vitals and findings on the spot. And so we were dealing with patients systolic of 200 and managing them with what we had available. Again, limited medication choices as well. So this is why it's really important as a physician, because now what we know we should do, ideally guideline-based, theoretically, and oftentimes what we practice in developed countries, now you're faced with the reality of lack of resources, lack of money from the patients, and their ability to access higher care, and you have to find a balance of the risk and benefit. And so oftentimes we'll be prescribing 2 medications, antihypertensives, to help manage that, and tell them to return to clinic within a week as a way to manage it. Same thing with the diabetes. We only had a few medications, and oftentimes patients who needed to be on insulin can't be on insulin because they don't have a refrigerator. They can't store the insulin in a safe way. They have to get the strips, they have to get the injections, and they don't have this money, and the clinic doesn't have supplies for all of them. So then we had to be really selective on which patients we decide to put on insulin. So these are some medical decisions that were very complex and interesting to make in that situation. Other very challenging medical cases or approaches were patients coming in with back pain or abdominal pain, and you had no investigations on you. So you had to rely on history and your physical exam. So this is why physical exam, honestly, nowadays I think is very underutilized in the American and Canadian healthcare systems. We just defer patients to getting a pan-CT scan or an MRI or ultrasound, and it's just very easy, and we don't really examine our patients as closely as what we learned in medical school, for example. But I found I was relying so much on the physical exam to figure out the diagnosis. I would be auscultating murmurs, and I'd be like, is this a systolic ejection murmur, or is this an aortic stenosis murmur? And the patient has bilateral peripheral edema. So does this patient need to go to the hospital for aortic stenosis workup, like an echocardiogram and acute heart failure management, or is this a normal systolic ejection murmur and the pitting edema is a medication side effect from their amlodipine that they started on 2 weeks ago for their blood pressure? So these are the kind of complex decisions you have to make in the moment. And also, you don't have necessarily significant time to think and plan for all these patients. And oftentimes you don't even have time to prepare in advance. You just pick up the chart, you see the patient, and you kind of just figure out on the spot. So time and efficiency is much short, and you are making bigger decisions. For example, you tell that patient to go home, just say, just stop the amlodipine. Now their blood pressure is going to go high. Or if it was aortic stenosis and acute heart failure, they're going to get worse to the point that they may die, they may have a cardiac arrest or an arrhythmia, or they have to go to the hospital and seek urgent medical attention and pay for all of that, which is going to be a lot more costly than having them sent for an outpatient echo and putting them on a diuretic. So each of your decisions actually carry a significant amount of downstream effects. And that was challenging, honestly, as a physician, because in the hospital currently, in the States, we just do pan scans and we just put them on medications and just assume they're going to get followed up by the family doctor and other specialists like a cardiologist, but we don't have that luxury in this environment. And so you really learn quickly how to manage with what you have available. And I think this is really good, because this skill that I'm explaining to you what it is, it's clinical reasoning. This clinical reasoning, I think oftentimes now is missed in modern day practice of medicine, because it's so simple, everything is so accessible. We just repeat CT scans every 5 days for patients, and we just put them on XYZ medications and just see how it goes, as opposed to really honing in on the history, physical exam, our diagnostic differentials, and using clinical reasoning. And so I think for a lot of clinicians, I would recommend you do something like this because it will improve your clinical reasoning, will improve your clinical decision making, and may make you a more efficient physician. I mean, sometimes I was working more harder at this medical clinic than I do sometimes in the ICU, because obviously we have downtimes in the ICU sometimes when it's not too busy or we don't have acute admissions. But clinics, I was seeing nonstop for 6-7 hours, patients who would come in, and you're making decisions about each of these complex situations for each of these patients. Though the benefits are, the patients are so grateful, they're so thankful. A lot of the patients would say enough respect or big up on you, and you learn a lot of Jamaican slang, and it was really nice to connect with people in that way. So overall, I thought it was a very beneficial experience, humbling in many ways as well, because on the last day of the week we did what we call house visits. So we went to local houses of people throughout the community who weren't able to make it to the clinic physically. So very elderly patient, we saw a 104-year-old patient, other patients who don't have any ways of getting around, patients who are wheelchair bound, bilateral amputations, etc., etc. So we saw a lot of people. And the humbling part is you get to see how they live. You get to see their houses. One gentleman lived in a hut. He just had one room with a bed and a dresser, but it was well kept and he was happy. So, some of these very human things that you get to see really affects you as a clinician, because you think from a medical perspective and you prescribe XYZ and you're like, this is how it should be to manage this condition. And then you look at the reality of what they're facing with, and then all of a sudden you're like, well, of course it makes sense why you're not able to take your medications or you're not able to improve your blood pressure. One woman, for example, had so much clutter in her house and basically locked herself in, and she thought that everyone was trying to harm her or steal from her. She would never leave the house. And when we look inside the room, it was just piled on with so many different medications, different junk, and you just don't know what medication is what. And you look at it, I'm like, I can't even tell what medication is what. How can she tell? And we were testing her. She's like, oh yeah, I can just tell by what I feel. But then she has 2 white pills that look the same size. So how is she going to know? And so these are some of the challenges that they face. And then you also face, because you're like, well, now you see the problem. What are you going to do about it? And we kind of narrowed down her medications from 5 to just the 2 essential ones. And we told them, this is what they look like, this is what they feel like. Make sure you take them twice a day, daily. And then, pray for the best, really. But then this is why a lot of patients need home visits. So all in all, I think very rewarding experience, not a significant religious element to it unless you want to be involved in that aspect. And overall, you feel like you leave a very significant impact, positive impact on the community and on yourself as well as a clinician. So I would highly recommend, if you have any questions or concerns about this experience, or you want to learn more, specifically about medical cases that we encountered or the religious aspect of things, feel free to comment. I'll be happy to answer. Thank you.